I'm here. Hello.
Okay, hello. Okay, because I was thinking maybe he likes to say a few words, but anyway, so. Hey.
No, it's all up to you, Zdravko.
Yes, okay. So, we can, I don't know, we can maybe start. Okay, so first, hello from Zagreb. I wish to thank Marek to initiating this COIL session. I will now start. We will start now with the lectures. So I hope that everything is going fine. Did you hear me?
Yes.
Okay. So we need just to share screen. Okay, you know how to do it. Okay. First, I will wish to thank you to Ivan Banovac and Dora. Ivan will make
recording in progress.
Okay. So the meeting will also be, meaning the lectures will be also recorded. And I will wish to thank Ivan Banovac and Dora Sedmak. Ivan will make, we will start with anatomical lecture first, and then my colleague Anna Aljinovic for the Clinical Hospital Center will do the clinical part. So if everything is fine, we can start. Okay. Ivan, your turn.
Hello. Just give me a second to share the screen. Okay, I hope everyone can see this. Yeah, okay, fine. So, hello everyone, my name is Ivan Banovac. I'm a teaching and research assistant at the Department of Anatomy. And in this first part of the lecture, which we titled Low Back Pain, What the Hell Hurts? I will present to you some parts that we called Lessons from Anatomy. So, first things first, in order to understand low back pain, we have to go a little bit back to basics and do a very quick revision of spinal nerve anatomy. So let's remember that we have a posterior root which carries sensory fibers and a anterior root which carries motor fibers, which join to form the trunk of the spinal nerve, which then of course carries both types of fibers, which we call a mixed nerve. The spinal nerve gives two branches, the posterior branch or the dorsal ramus, which also carries mixed fibers, as well as the anterior branch or the ventral ramus, which once again also carries mixed fibers. And now let's get to the main anatomical causes of low back pain. So there are several possible causes. We have here identified the 6 main ones. First, the spinal nerve and its root. Then the muscles of the back. Then the vertebrae themselves, or the vertebral column. Then the vertebral joints. Here we mean specifically the zygapophyseal joints, so the small joints of the vertebral column. The intervertebral disc. And finally, some causes of low back pain can be due to referred pain, so pain that projects from other parts of the body, such as the inner organs. For example, pyelonephritis is a cause of pain in the back, but not related to the structures of the back. In the next part of the lecture, we will focus on basically one concept, which is herniation of the intervertebral disc, and how this concept can be explained on a purely anatomical level to grasp all the clinical implications and all the clinical signs and symptoms. So, in order to understand the pain associated with intervertebral disc herniation, there are 5 key anatomical concepts that we have to explain. The first concept relates to the ligaments of the vertebral column and the vertebral openings, the vertebral foramen and intervertebral foramen. Then the second concept relates to segmental innervation. The third concept relates to so-called indicator muscles. The fourth concept is based on the differences between the cervical and lumbosacral spine. And the fifth concept relates to the types of herniations of the intervertebral disc. So let's start with the vertebral ligaments and explain the two ligaments that are most important for understanding intervertebral disc herniation. The two ligaments that are important for this are the longitudinal ligaments, the anterior longitudinal ligament, which we see here. It's important to understand that even though this ligament is structurally a little bit weaker than the posterior one, it is much broader and encompasses almost the entire circumference of the intervertebral disc from the anterior side, which makes anterior herniations less likely to occur. Of course, we will see next that even if anterior herniations would occur, that they would be clinically much less significant than posterior herniations. Then we have the posterior longitudinal ligament, which is stronger than the anterior one. However, it is much more narrow and leaves a lot of space in the lateral portions, which means that posterior herniation of the intervertebral disc typically occurs where the intervertebral disc is not covered by the posterior longitudinal ligament. It can also occur where the disc is covered by the ligament. However, then there must be also some kind of structural damage to the ligament underlying the condition. Next, we will talk about the relationship of the intervertebral disc with the spinal cord and the spinal nerves. First, it's important to understand that the spinal cord is directly posteromedial to the intervertebral disc, while the spinal nerves are located posterolateral to the intervertebral disc. And regarding the relationship of the intervertebral disc within the intervertebral foramen, here we see the disc, and here we see the root of the spinal nerve. Once again, the roots are typically located posterolateral to the intervertebral disc. Next part is about the segmental innervation, which we need to understand in order to grasp the clinical signs and symptoms that will be a consequence of intervertebral disc herniation, which compresses a certain spinal segment. Here we will introduce two terms, myotomes and dermatomes. These terms have somewhat different meanings whether we use them in embryology or anatomy. However, in anatomy, we usually use them in the following sense. So myotomes are all muscles that receive motor innervation from the same spinal segment, while dermatomes are all parts of the skin that receive sensory innervation from the same spinal segment. Since each spinal segment has a specific area of motor and sensory innervation, this means that damage to a certain spinal segment or spinal nerve that exits a certain spinal segment will cause specific clinical signs and symptoms related to the affected myotomes and dermatomes. Following up with the segmental innervation, we have the concept of multisegmental and monosegmental innervation of the skeletal muscles. Typically, most muscles receive innervations from several spinal segments, and therefore, we call this type of innervation multisegmental. However, there are some muscles that receive either predominantly or even exclusively innervation from one segment. we call this monosegmental innervation. If such a muscle loses function due to neurological damage, such loss of function indicates which segment of the spinal cord was affected by a lesion, and that's why we call these muscles indicator muscles. We have to now go to the relationship of the spinal nerves to the cervical and lumbosacral spine. Since herniations basically occur mostly either in the cervical spine or in the lumbar spine and the sacral segment of the spine, we will talk about only these two parts. So we will now not mention the thoracic spine in as much detail. The first concept that we need to explain is the relationship of the exiting spinal nerves to the corresponding vertebrae. Briefly, the cervical spinal nerves exit the vertebral canal above the corresponding vertebra, because the first cervical nerve exits above the first cervical vertebra, and this just continues. And it flips around in the lumbar and sacral spine, where the lumbar and sacral spinal nerves exit the vertebral canal below the corresponding vertebra. So, for example, the L2 spinal nerve will exit the vertebral canal below the L2 vertebra. However, this is not the only difference between the cervical and lumbar spinal nerves, because we have an important difference in their course. Cervical spinal nerves are horizontally oriented while coursing through the vertebral canal and the intervertebral foramen. However, lumbar and sacral spinal nerves are obliquely or sometimes even vertically oriented while coursing through the vertebral canal and intervertebral foramen. This is because the spinal cord ends at the level of the first and second lumbar vertebrae, and the rest of the spinal nerves have to descend through the spinal canal or the vertebral canal in order to reach their appropriate spinal segment. This has some consequences which are important for intervertebral disc herniation in the lumbar and sacral spine. The consequence is that while we also in the lumbar and sacral spine have something we call exiting nerves, which at any given spinal segment is the spinal nerve that exits the vertebral canal at the observed segment. So, for example, the L4 nerve or L4 spinal root, here depicted on the picture, exits the spinal canal or the vertebral canal beneath the L4 vertebra. However, due to the oblique course of the lumbar spinal nerves here, we also have a traversing nerve or a traversing root. In this case, for the L4 segment, this is the L5 root. So the traversing root, which does not exit at this level, but rather one segment below. And thus we define the traversing nerve or the traversing root as the spinal nerve that traverses through the observed spinal segment, but exits the vertebral canal one segment below the observed segment. This is specific to the lumbar spine and is not present in the cervical spine, where we have only exiting nerves. And finally, when we combine all of this with different types of herniation of the intervertebral disc, we can understand how these different types of herniation affect different anatomical structures and can thus have different clinical presentations. Even though there are numerous types of anatomical types of intervertebral disc herniations, according to different classifications, even up to 7, 8, we will here describe only 3 that are fundamentally different and cause fundamentally different clinical presentations. The first one is so-called posteromedial herniation, sometimes also called central herniation, which basically means that it's a herniation where the intervertebral disc protrudes immediately posteriorly, so in the central part of the vertebral canal. If this occurs in the lumbar or sacral spine, such a herniation will affect the entire cauda equina. This is the part of all the spinal roots which descend through the vertebral canal. So all the lumbar and spinal and sacral spinal roots that descend through the vertebral canal. So this is a consequence of posteromedial herniation. Such herniation is rare because usually the posterior longitudinal ligament will prevent such a herniation. However, if it occurs, it causes compression to all the lumbar and sacral nerves at the same time, and is therefore very serious. This is a very serious condition which requires surgical intervention immediately. A much more common type of herniation, and the most common type, is so-called posterolateral or paracentral herniation, where the herniation of the intervertebral disc occurs right next to the posterior longitudinal ligament and compresses in the lumbar and sacral spine the traversing nerve, which means that it actually compresses not the nerve of the same segment, but the nerve of one segment below. Finally, there is the lateral herniation, sometimes called far lateral or foraminal herniation, which is where the intervertebral disc protrudes even more laterally and basically compresses the exiting nerve. When we combine all of this, we can understand now that different types of herniation can affect the same segment. Here we see that dorsolateral herniation of L3, L4 intervertebral disc and lateral herniation of L4, L5 intervertebral disc will both affect the L4 spinal segment, so the L4 spinal root. However, the other way around also applies. So the herniation of the same intervertebral disc, depending on which type of herniation it is, can affect different spinal segments. For example, herniation of the L4, L5 disc, whether it's lateral or dorsolateral, can affect either L4 or L5 spinal segments. And finally, to conclude, the key message from all of this is that the clinical presentation of the intervertebral disc herniation depends on three factors, which can all be understood by knowing basic anatomy. First, the clinical presentation depends on the part of the spine affected, whether it's the cervical spine or the lumbosacral spine. Second, the clinical presentation depends on the type of herniation. Three basic different types exist: posteromedial, posterolateral, and lateral. And thirdly, the clinical presentation will depend on which spinal nerve is affected, whether it's the entire cauda equina, whether it's the traversing nerve, or whether it's the exiting nerve or exiting root. Thank you for your attention. This is the end of the anatomical portion of the lecture, and we will soon continue with the clinical aspects.
Hello to everybody. My name is Aljinovic. I'm physical medicine and rehabilitation specialist, and I'm going to continue with the clinical aspects of lower back pain. It was a really nice anatomic presentation, and I'm glad that my presentation is following this one. What I would like to tell you is that a lot of people have low back pain. And when I'm saying a lot of people, it says in the literature around 84% patients will have, or the population will have low back pain at least once in a lifetime. But many of those will have repeated pain, and many of those will be on a sick leave and even be left with a chronic impairment. When considering back pain, we don't have many specific causes. Most of the back pain is kind of vague when you think about it. We can't really pinpoint the exact cause of the back pain of the patients that is in front of us. Still, when you think about it, the low back pain costs a lot. And on an annual year, you have here some numbers. So we have a lot of sick leave days, and we have people who are not able to do their work, either physical, or people who sit a lot, or people who have to clean, or even if you're an intellectual and you have to do some intellectual work, if you have a chronic low back pain, then you are not concentrated, and that also leads to a lot of sick leave days. You heard Ivan telling us exactly what can be inside your spine and what could be the cause of the pain in your lower lumbar spine. However, there are many reasons that can be underneath, and we have to see and we have to explore and find if there are which is the most probable and how we are going to treat it. First, when we see the patient, we look the way he enters your examination room, the way they have their posture, the way they walk, the way they address you, if they are cheerful, depressed, or their general aspect of that patient. And then you start with a history. You want to know how long is this pain present? Is it coming and going? Is it still always there? Is it worse in the morning, in the evening, or during the night? Because the timeline can give you some ideas about the causes of the back pain. If you have more back pain in the morning, you have to think about rheumatological diseases. If you have more pain during the overload, then you have to think about some mechanical reasons. Then you always have to ask for the exact localization. Is it only in the lower back pain, or do you have some pain in your and tingling in your legs, either one leg or both of your legs? Then you ask for the trauma, of course, if there was any, and you ask for the work history and also for the physical activity, because many of our patients are not enough physically active, but many of them are also too physically active. That could also bring to some derangements and lower back pain, of course. You have to always ask about the medical history. We are especially careful about cancer patients because some cancers give more bone metastasis than the others. And you have to always have that thought in the back of your mind, not to miss that kind of cause. There are defined red flags, special questions and special answers when you have to be more careful, and that will require further workup with those patients. If you have a persistent and really strong pain, if you have a night pain, that you have to think about the cancer in those patients. If you have an elevated body temperature, there is a possibility you have some kind of infection, or either of the bone or the intervertebral disc. If you have weight loss, if the patient is sweating, if you have incontinence, you have to think that the cauda equina might be affected. And then people who are on the immunosuppressions, especially now patients that are receiving the biological therapy for various reasons, like Crohn's disease or the rheumatoid arthritis, they have the altered immune response to the infection. And sometimes that infection can be presented in a non-typical way. So you always have to ask for that. And of course, the neurological symptoms are really important. The way they control their sphincters, if they can have the full strength of the legs, if they can walk undisrupted, it's really important to ask those things. If you have anything that the patient is answering yes to those questions, then you have to see if you need to react more promptly and refer him to the further investigations. You always have to look at the patient. You have to undress the patient. It's not enough to see him standing and walking in front of you. You have to see how that spine is bending, how you can have, what's the range of motion of that particular patient. And if he has pain in one particular position, because sometimes if the pain is more pronounced when you lean to the back, you have to think of the small joints, apophyseal joints of the spine. If the pain is more pronounced and goes to the leg, if you move to the other side, then you can think about disc herniation. If you have the pain that is related to the movement of the pelvis, that can indicate that you have kind of weakness, relative weakness in the spine, and that you have to strengthen the paraspinal muscles. So everything you see in the patient, it's really important and can give you a clue what is going on beneath. You always have to palpate the muscles around the spine to see if they are tight and if they are painful. Also the gluteal muscles, especially the part of the piriformis muscle that can compress the ischiadical nerve and give symptoms. We always check the reflexes to see if they are symmetrical or asymmetrical, or there is an absence of the reflexes, and you can then define the level of the injury or the root that is affected. And you also check with the manual muscle test the strength of the muscles by the groups, also to see if you can define the root that is affected. We have something also that we called the neural tension test, and LASEG is probably the most famous one. The way in particular positions you can stress the nerve, and you can see if there is a compression of the nerve and if you can reproduce the pain, and then the neural tension test is positive. When considering referral to the diagnostical tools that you can use, we usually use the X-ray, but we use it not so much as we did before because we have better tools. We have the MRI that is more precise and more detailed. Gives us more information than the X-ray itself. Sometimes, if we can't perform the MRI because the patient has some kind of metal or other contraindication, we can use the CT, but it's not so detailed and it's not preferred for the imaging of the lumbar spine. We can also sometimes send patients to the bone scan, especially if you want to differentiate if patients has metastasis or some benign change on the bones, and the bone scan gives us good information in that field. The guidelines are a bit of strict when sending patients to the imaging to the radiology, because if you don't think that this image is going to change the way you treat the patients, then it is not worthwhile sending patient to the either X-ray or the MRI. The other thing is that the picture is not always correlated to the way the patient presents. You can have a really big degenerative changes in the spine, and the patient that has a minor complaints, and the vice versa. You can have a really small changes on the MRI, and you can have the patients that is barely walking because of the pain. So it's not always indicative of the way you're going to treat that patient. What we always need to, when we need to always refer patient to the diagnostic tools, that is when you have a red flags and when you suspect something else is going on. We always have to exclude if there is a tumor, if there is infection, and if there is a fracture. That is what we need the most from those imaging. What is the most common nowadays is the postural syndrome. It's the easiest to treat, and but you have to convince your patient to change his lifestyle a little bit and to start exercising a little bit. It's not easy because you're not going to die from a low back pain, and you have to be really motivated to start some changes in your life. Most of the people are not willing to do that because the lower back pain comes and goes, and when you're feeling better, you tend to forget what happened and you go back to the usual way the people behave, and it's not good for our spine. In that postural syndrome, we have something that we define as myofascial syndrome, and we believe that the muscle is too tight and the muscle itself can be the source of the pain. We treat it in different ways, but if you apply heat or if you stretch a little bit, most of the pain can go away. Usually we apply cold to anything that provides pain, especially when you put it on a shoulder or a knee. But the back, even if it's in acute phase, really likes heat, because when you apply heat to the muscle relaxes, and most of the pain will go away with a simple thing such as the shower is. Then we have many other changes that you can have on the spine, and with considering the disc and the roots and the end plates itself. Ivan told you a lot about it, so I'm not going to repeat it. What I like to emphasize that with a chronic lower back pain, you have changes in the feeding the disc, but because the disc itself doesn't have its own vessels, and it has to produce osmosis from the vessels in the end plates of the vertebral bodies. And if there are many degenerative changes in the end plates, then this feeding of the disc is disrupted, and you have the degenerative changes in the disc also. And that leads to the various types of changes on those vertebral bodies that are defined as modic changes. And there are 3 stages, really. In stage 1, you have the inflammation and you have the bone marrow edema. That is an acute phase, and that could be the most painful in when those changing starts. Then you have the fatty degeneration in second type, and you have the sclerosis of the bone in the third type. The body tends to mend itself. Then those changes are therefore happening, and the creation of the osteophytes, the lumbar spine is trying to stabilize, to minimize the movement and to minimize the pain. So sometimes you have the people in 40s and 50s that have a lot of pain, a lot of trouble, but when they are older, they seem to have a lot less of the symptoms. They have pain sporadically, and they are a lot more, they are easier to treat. Even the pictures or the imaging results are worse than they were 20 years ago when they came for the first visit. Then what you have to always consider, especially if you have the pain in both legs and the pain that is getting worse with walking, especially walking for a shorter period of time, then you can have a spinal stenosis. People can always also adapt to the spinal stenosis, so it's not the absolute indication for the operation and for the opening of the vertebral canal. But if you have neurological symptoms and the pain that doesn't go away, then you have to consider surgery in those cases. If the spinal stenosis is developing slowly and through many years, then people can really have narrow spinal canal, but with minor symptoms and symptoms that don't require any surgical intervention. And there is also the question of the osteoporosis that is now common, and we are trying to treat it. At first, there was a thought that osteoporosis doesn't hurt and you can't feel the pain, but you have a microfractures and you also have bone edema, and when you have those kind of changes, you can also feel the pain. So the osteoporosis can also produce pain in the lumbar spine. And this is something that we fear the most, and we fear the most because the tumors are really rare in the lumbar spine, considering how many patients have a lower back pain. And you have always, I'm always concerned that I'm going to miss it. So I always check and recheck patients that are coming back and we haven't helped them in a way we wanted to, and the symptoms are always present. So we don't have to do the MRI on the first time the patient comes, but you have patient that is coming back and the pain is persistent. Even if it goes away a little bit, it can be present, and then for a couple of days that the patient has a minor symptoms, and then back to the much more pain. You have to consider there is something else going on in that spine. And what is worse and what is most challenging when treating lower back pain is the pain that is becoming chronic. When you have pain for a long time, for years, and it's coming back, and some patients adapt to that pain and they can live with it, and they come only if the pain is getting different or it's getting worse or it's different in character, they come again. But there are patients, they repeatedly come to your office and they come and they come, and you can't treat them the way so that you and the patient would be satisfied with that. And what is, how is that explained? It is explained by the central sensitization and the changes on the cortex itself. Around 15 to 20 years ago, they started research on that subject, and they really found that the pain is changing the brain. So you can't treat, you don't have the nociceptive impulse in the lower back pain anymore that can explain the pain the patient is feeling, but there is a constant pain and in that area. So you have to consider that there is central sensitization developed in that patient. We have some standard guidelines, the way we treat the patients and the way we step by step address their problems. First, what we try to is remove the pain, not the cause, but the pain itself. And we start with drugs, of course. What's recommended as first line drug are non-steroid anti-rheumatic drugs. And you have to use them for a short, not so many, as little as you can to cope the pain, and not for a long time, because there is kidney toxicity, there is heart toxicity, and you have to think about it too, because we prescribe a lot of non-steroids, and when we talk to the nephrologists, they really are freaked with that, because they see a lot of acute renal failure with non-steroids, and they are much more cautious with those drugs than we are. So you have to think about the toxicity, and you have to think of gastrointestinal side effects, because you can produce bleeding with those drugs. If you can't use the non-steroid antirheumatics, you can use paracetamol, and you can use the weak opioids, but they are not the first-line drugs for the lower back pain. We sometimes use the anti-epileptic drugs, because we think there is a neuropathic component to that pain the patient is feeling, and also the antidepressants, but we try not to include them as long as we can cope the pain with the other ones. What is really, really important is that you explain to your patient what can he do for himself to stop feeling pain. It is really important to change the way you are sitting, you are walking, or you're just standing, the way you sleep in your bed, the way you lift heavy weights. That can really help your spine to be better for a longer time. And our core business in treating lower back pain are exercises. You have to convince your patient that that is the drug that he needs. And also, not every exercise is for every patient, and not every lower back pain is the same one. If you don't have anything on the MRI, and if you don't have anything in a clinical examination except the pain in lower back pain, you have to see if your patient is more kind of stiff or more flaccid. Because if you have somebody that can move with a more than a full range of motion, then you have to perform exercises that will make that spine stable. But if you have somebody who has really stiff muscles and cannot move that much, then you start with a more relaxation and the stretching exercises than with the building the tone of those muscles. So it's really important to see your patient and to tell your therapist which way to go with that patient. It is also important for everybody to know that by exercises, you can produce hyperalgesia. You can feel less pain. If you exercise for half an hour, you can feel less pain for at least half an hour. And that is a kind of rule for the healthy patients. It is kind of more complex when you have a chronic back pain. Then sometimes at first you can have more pain, hyperalgesia, with the exercises, but you have to then dose those exercises to see the specific type and the specific time those patients can exercise, and that can also produce the feeling of less pain in those patients. And also what we usually tend to put away a little bit is psychological therapy. And it is really, really, really important. So you have 3 things that are in guidelines that can help with lower back pain. And those are psychological therapy, exercises as the first thing, and education. All those other things can help, and patients might think that help, but on the larger scale, on the large numbers, we haven't found the statistical difference that can suggest that those things are really working with the lower back pain. Manual therapies tend to ease the pain in the way because therapist opens the canal, the spinal canal and the canal where the foramen, where the root goes, and that releases the pressure and releases the pain. The therapist also can ease the stiffness of the muscles and also contribute to the less pain. But the manual therapies can only be used as a part of the treatment, together with, as I told you, the psychotherapy, the education, and the exercises. All those other things that I'm going to shortly mention, we use them, all of them, but they don't have really proof that they can treat the lower back pain. One of those is lumbar support, also the acupuncture or the traction that is came back now. For the 30 years we haven't used the traction, and now we are starting to use it again. It's beginning to be more popular once again. And all those electrotherapies, they are really comfortable. People like them, and they have some kind of way they can ease the pain, stimulating the mechanoreceptors and the opioid system in the body, but their effect is not, it doesn't provide the cure for the lower back pain. However, we have some new passive physical therapy methods that we can use. One of these, or those are superinductive system. We have a really strong magnetic field that goes up to 1.5 Tesla, and it creates a magnetic field in impulses and goes more deep in the organism and actually contracts muscles. And we think there are different ways, the way this method is treating the pain, the way it changes the pain pattern on the peripheria, the way it stimulates the mechanoreceptors and the opioid pathway in the organism. So we don't have a lot of research done on this subject, but this may prove to be more effective than the usual electrotherapy methods we use. We also like to use a lot of proprioception in the rehabilitating the lower back pain, and technology has also provided us a lot of devices that we can use and help us to explain to our patients the way they can use their body in the treatment of the lower back pain. There is saying that just riding in a tram can really strengthen your back muscles, because you have to balance all the time and when you're standing in the tram, and that can be also therapeutic exercises for the lower back pain. There are also some relatively new ways to treat headache and to treat the brain itself, and it is being also used in the lower back pain with a quite good results. And if this all fails, we have more invasive treatment for lower back pain. We can apply some spinal injections. We can do the radio frequency denervation or epidural injections, or we can refer our patient to the surgery, to the specialist who can perform the spinal decompression or disc replacement, or whatever is indicated in the patient that we can't treat in a conservative way. I would like to emphasize at the end of this session is that we have a lot of evidence and a lot of knowledge or what can really produce pain and lower back pain in our patients. But no matter how much we know, and we are really still treating them not so successfully. Still, if you think about anatomy and if you know how the spine moves and where the root goes and what could go wrong in the spine, that you can be more successful in creating successful strategies for treating your patients. I hope this was really interesting for you, and if you have any questions, we are here to answer them. Thank you.
Как се ми появи?
Ja nas čuju.
Čujemo vas.
Čujete?
Okay, so so we can start with the questions. Are there some questions? Please just be aware that you all are muted. So if you like to ask questions, but Andrea, you can unmute. Is there maybe Andras? Do you have some questions? We can start there. So, da ga samo unmute. Okay.
Can you hear us now?
Yes. Okay.
So I asked my students, they have no questions. So we have to come up with some questions. So what is the most frequent type of diagnosis you are coming up with? I'm asking this from the clinician. So what is the most frequent type of diagnosis you have for the back pain?
Oh, the most frequent is the pathology of the disc. We don't have to have the herniation, but we have the pathology of some parts of the annulus fibrosus generated, and even if the disc is not moved not so much, it can give, you can feel pain. So that's the most common thing we have.
And one more question. How frequent is back pain among medical students?
Oh, not so frequent when they are young. So when I asked them on their second year, most of them didn't experience, maybe 1 or 2 in 30 of them. That's my experience. They have a lower back pain, but as they grow older, as they study more, there is more lower back pain.
Mm-hmm. So is this a problem among doctors, medical professionals, more frequent than compared with other professionals?
No, I don't think so. No.
Okay.
We have the most people who come are people who are sitting a lot, even more than those who do the physical work.
Mm-hmm. Mm-hmm. No more questions.
Thank you.
It was a very nice presentation from both of you. So I think, did you enjoy it?
Yes.
So our students here in Pécs, they are studying now splanknology. They have already done their anatomy course in limb anatomy. But we have here one German student, who is studying neuroanatomy already. So that's the composition of our.
Say this. Me? Okay.
Hi, we have a question here. Can we ask it, please?
Of
Okay, so we have a student who is interested in referred pain. Can you hear as well?
Yeah, we can hear you.
Brilliant. So just please give us the question.
Which one is the most common cause of like referred pain related to the spine, like in general, to the lower spine?
Mm-hmm. Okay, so there are several causes of referred pain. I'd say how common they are also depends on which part of the spine we are talking about. If we are talking about the lower back specifically, then probably referred pain from the kidneys. Also, something more on the region, the thoracic region, but also on the thoracolumbar segment, you could have referred pain from the pancreas, for example. Or, for example, if you have referred pain in the region of the scapula, so the upper thoracic or lower cervical segments, that's basically referred pain usually from the vesica biliaris, so from the gallbladder.
Thank you so much.
Thank you. Thank you for the presentations, by the way. It was so well done, both of you. Well done. Thank you so much.
Thank you.
Yeah, could I ask a question if that's all right?
Yes, sure.
I was wondering, I understand obviously because it can be very chronic conditions and can be very difficult to treat low back pain. Some patients may turn to sort of unfounded alternative therapies. How do you kind of deal with that when a patient asks you for advice on how should a clinician really deal with that if a patient asks for an advice on an alternative therapy that has no scientific basis?
Well, we start according to the guidelines, of course. You don't have to really start with a lot of analgesia, because if the patient is adapted to that pain, then you have to come in conclusion with the patient if he needs to take drugs or not. But you have to make him understand what he has to do to ease the pain. It's chronic, but it can be treated. You have to make the patient understand that it takes time. I always tell them it takes maybe 3 to 6 months when you start exercising and when you start changing your lifestyle to feel that something is improving or changing. So you have to give yourself and the patient the time. But if it comes back and he didn't apply all those things he was advised, then you know that you have kind of difficult patient, and you change your strategy. Then you start with all those things that are not in the guidelines. You try to ease the pain with electrotherapy, magnetotherapy, and other things that have a short-term effect, but can help patient to communicate better with you and to start all those other things you're expecting him to do. We don't have many patients that are really miserable with that. Some are, but most of them have the pain in the periods of time, and they can cope with that, and you can help them cope with that. We can't cure them, most of them.
Thank you.
Welcome.
Okay, nothing in the chat.
Mhm. Do we have some more questions?
Okay.
Just a second. Okay, so we have a question on YouTube. Anna, Ivan, you can hear me, right?
Yes.
Yes.
Okay, so Professor Vedran Katovic, I'm sorry to have been on and off. My question is about the cutaneovisceral reflexes regarding referred pain in the lower back.
Mm-hmm. Anything specific or just in general? Andrea?
Well, I suppose in general, he just have written as that, about the cutaneovisceral reflexes regarding referred pain. General, he said general.
In general, okay.
General.
So, yeah. When we are talking about cutaneovisceral reflexes, basically there's I'd say it like this. So in some cases you have how
Stimulus.
yes, a stimulus, sorry. I just couldn't find the word. So a cutaneous stimulus which can have a visceral effect. For example, if you touch the skin on the abdomen, then the peristalsis of the can change, and the pain in the abdomen can be affected. Regarding the lower back, I'm not sure which would be an example of something like that, but there is some internal organs that have this referred pain regarding to the lower back, which we mentioned earlier. Yeah.
No, okay.
Okay, thank you. Do we have some more questions? Okay, so we have a comment from Professor Katovic. But this is why so many people choose alternative approaches to treating lower back pain, like cupping.
Yes.
Yes, I agree.
Well, I haven't mentioned there are many ways you can treat them. You can treat the fascia, you can use the Bowen method, you can use the other manual therapies. But the exact way they help, we are not sure about. And there is always time that lessens the pain. So we have to be careful if we say something is really working or not.
I have a question.
Yes?
Related to this comment. Do you have any estimation? What is the percentage of patients who try to seek for help first in alternative medicine, and they waste a lot of time because of mistreatment, and they come to real treatment just much later when you cannot help them very much? So is there an estimation of these kinds of patients? What is the proportion of these kinds of patients who do not get treatment in time because they seek help first in alternative medicine?
My experience is it's the other way around. Here, most of the people start with official medicine, and if that doesn't work, then they try everything else they can find. There are some, and some have also done poorly because of that, but not many.
Thank you.
Welcome.
Okay. So thank you for I think this was very nice as a first try of this COIL event. The anatomist presenter was very good, I have to say. To summarize the anatomical backgrounds, it was really nice. Just to give you a feedback, I think
Thank you.
Very good too. It was very easy to follow. It was very good summarized. So congratulations to the anatomy department. Of course,
Okay.
the clinical part was very interesting also. Thank you.
Okay, we have I think from Masaryk University there is some
Yes,
question.
we have one more question here. Thank you.
Yeah, first, hello and thank you for your presentation. It's amazing. And about the intervertebral disc, we said like there is some postural medial, posterolateral, and more lateral disc. And I wanted to know, like, when this nerve ending axis, like blocking, like this disc is like blocking the nerve axis, the nerve root axis, like after a while, it can be that like this pain goes away. Yeah. But like how, like what will happen to this nerve that it says, okay, for example, after like 1 month, I don't have that pain anymore.
Mm-hmm.
But it's still same, like it's still a problem with the lateral lateral intervertebral disc problem.
Oh, okay, I think I understand the question. So the question basically, if I understand correctly, refers to, can the level of the pain change after some time, or can the pain diminish by itself, for example?
Yes, exactly. Okay. Exactly.
So theoretically, desensitization exists. So in some capacity, maybe a person can get a little bit used to the pain, but pain that has this type of cause, where something is compressing the nerve, is usually quite resistant to this. So I think people who have intervertebral disc herniation will usually experience quite a lot of pain and will seek help definitely before they would get to any stage where such a process would matter. Something that I didn't really mention in the presentation itself, but maybe I can mention it here, is that not every herniation will cause symptoms, okay? Actually, a lot of herniations are asymptomatic, at least at the beginning. There are different degrees of herniation. Some are less severe. We usually call these protrusions, and some are more severe, and we call usually these extrusions. So also the clinical symptoms will depend not only on these anatomical aspects, but also on the degree of herniation. So just keep also that in mind. This was a generalized case, so where we imagined that all of these situations were symptomatic, that they produced symptoms. Also, speaking from a clinical standpoint, sensory symptoms are more common than motor symptoms, because motor symptoms usually occur much later. So even though indicator muscles are very useful in diagnostics, it's not something that you will usually find at the beginning of the process, only after someone has not been treated for quite a while. Okay.
Look, there is a dynamics to that, because you have still a little bit of space for the root to go away from the disc. So when you have the acute inflammation, you have a lot of pain and the sciatica or whatever you have to at that point of time. But the inflammation is treated, then the nerve root, there is more space for the nerve root in that area. And also, if you bend a little bit forward or a bit sideways, then you open the foramen, and then the nerve is not compressed anymore. You have to also take into consideration the small joints, because if they are changed and the ligamental flora is getting bigger and the joints are generatively changed, there is less space for the nerve to move, and you have then it's more difficult for the patient to treat. That's why all those manual therapies are effective, because if you position the patient in the position when you open the canal or the foramen, then you have less pain, and you give the nerve a chance to recuperate, to mend itself. Yeah.
Okay, thank you so much.
Thank you very much.
Okay. Do we have any other questions? Okay, if not, I would wish to thank to all of you who attend this lecture. There were also around 40 people on the YouTube stream, so at least we show that it can work. It was no really, I hope that the technical things were working nicely. I wish also to thank to Andrea, Matija and Tin Luka, who helped us this technical things, and of course to presenter to give the lecture. So if we have any further question? No, we don't have it. So if there will be any other questions, we will post this to good effect there. Okay, we can one more question for the end. Okay, so
how likely it is for an individual to do more harm than good if exercising on their own?
If you are listening what your body is telling you, then you probably won't do any harm. But if you push And if you exercise regardless of the pain, then you can do harm. Because all those advices that I give to my patients, they usually say, oh, yes, I do that. I came to that position myself, because the body is positioning you in the way that hurts less. So if you're listening to your body, you won't do harm.
Okay, so I think this we can take as the last question. So we are happy to see us soon. I don't know in how many times. So there is also to leave there. Okay, so Marek is here. Also thank again for Marek to initiating these seminars, and see you soon in I'm not sure when is the next
on the 18th of November.
Okay, on the 18th of November. Okay, I was thinking it was 18th of October, thinking that we will be not the first one, but anyway. Okay, so see you soon, hope, and
thank you very much again. Look forward to the next one, but thank you for such a brilliant start. Thank you.
Okay, thank you.
Bye. Bye.
Bye.
Bye. Thank you.
Thank you.